From Ausmed Education, hello and welcome to episode 7 of the Care to Learn podcast series. I'm Wayne Woff, and each month we feature interesting and influential professionals working within healthcare and education. This episode will be a little different, as we had an extremely rare opportunity to record our guest, Dr. Pamela Payne Foster, at the recent International Rural Nursing Conference held in Nashville, Tennessee in the USA. Dr. Pamela is an incredibly inspirational personality. She is a preventative medicine and public health physician, professor in the Department of Community and Rural Medicine, as well as the Deputy Director of the Institute for Rural Health Research at the University of Alabama. I'd absolutely highly recommend you watch her TEDx talk on bridging civil rights and healthcare. This episode addresses social justice in healthcare, with a focus on the health disparities that affect various racial groups. Pamela discusses the incredible work she's conducted in relation to HIV AIDS and how she managed to engage religious communities to embrace the condition as a social justice issue rather than a stigmatised disease, leading to greater community acceptance and ultimately treatment in a largely underserved population. This episode is truly not to be missed, and Dr. Pamela Payne Foster is a great living example of our mantra, Care to Learn. So let's get into it.
Hello, this is Dr. Pamela Payne Foster, and I am doing a follow-up podcast from a presentation I did recently in Nashville, Tennessee at the International Rural Nurses Association meeting. I am currently a professor, starting 8/16/18 at the University of Alabama School of Medicine, Tuscaloosa campus. I'm also Deputy Director of the Institute for Rural Health Research here at the campus. So my work has mainly been working in some of the rural African American communities here in Alabama. My father is a native of rural Alabama. Most of you have heard of the town called Selma. Selma, Alabama is his birthplace. So I have just been proud to work in communities like Selma and others in the rural South, rural Alabama. So what I'm going to do is just give some highlights of some of the things I talked about, really to help spur conversation around these issues. And one thing I did was I started out with some definitions to really kind of bring us in the mindset of how we can really frame social justice in our work with health disparities. So many of us know the definition of health disparities is really comparing two populations and looking at the differences in their health outcomes. Usually, in the context here in the United States, we look at racial ethnic groups like African Americans or Latinas, and we compare them to the standard of another larger group like Caucasians here in the United States. Now, that's not always the case. For example, usually the minority groups have worse health outcomes than our Caucasian majority group. But in a place like South Africa, a country like South Africa, where Native Africans might be the larger population, but they might have worse health outcomes. So that's our definition with health disparities, really comparing the health outcomes between two different populations based on something like race or ethnicity. That's what I call sort of a two-dimensional sort of definition. And I'd like to shift to a newer definition, which I really call a three-dimensional, because it gives us a little bit more information about the differences between groups. And this is what we call health inequalities or health inequities. So more of a three-dimensional definition because it really incorporates not only the differences that we can see between the two groups, but really trying to understand what is the root cause or what are some of the underlying causes that cause the differences between the two groups. Certainly, underlying causes like generational poverty or history. Certainly, when I look at some differences between blacks and whites here in the United States, I always have to go back to the history of the transatlantic slave trade and slavery in these places. Even though it happened 200 years ago, they still can have repercussions down the line generationally. Same thing for colonization, even in a country like Australia where you had natives who were there. Why is their health outcome different perhaps than those colonizers who came? Of course, that history of colonization brings with it oppression, and which leads also to the poverty. So all of these things are issues. And really, when we talk about these health inequalities, they are really social issues. So it makes it very difficult for those of us who are trained as physicians or health care providers, like nurses, nurse practitioners, when we are trained to really look at the science of the body and deal with giving a diagnosis and giving treatment. Sometimes we miss that underlying cause of disease or some of the health outcomes, poor health outcomes that we see. So that's really the premise of the work I've been doing to try to get to that, get a little deeper and delve a little deeper into why we have to begin as healthcare providers to think in a different way. Now, I'll give one example that I use in my own research, but also let me just go now to talking about how we could overcome some of these barriers. One is with training. Like I said, most of us are not comfortable dealing with social issues because of our training. We haven't been trained that way. But of course, we have colleagues who have been trained that way. There are people who are trained in medical anthropology. There are social workers. There are other disciplines, psychology, other social science disciplines that we really should begin to partner with in order to solve some of these health inequality issues. So that's one way. Or as a clinician, we can go back and get another degree. I worked in the area of bioethics before, so I'm my last boss where I worked at a National Center for Bioethics at Tuskegee University. Most of you have heard of the Tuskegee syphilis study, so they have a national bioethics center there, the only one that's really focused on underserved communities, minority communities like African Americans, Native Americans, Latinas. But my boss was a retired cardiologist who went back to school to get a degree, PhD in philosophy, and that's how he got into the area of bioethics. So thinking about even combining degrees for training or combining training programs to really get the kind of product we want, it's interesting. I'm a preventive medicine public health physician, so I had public health training as a part of my residency training. I got a master's of public health. I think the idea of training around population health rather than so patient centered, to really think about having people who are trained as population scientists as well as social scientists is great. So that's one way. Another way would be partnering with a social scientist, which I think is always a good way to sort of deal with these very complex issues. So back to my example of HIV AIDS. I work in this area. I came to it actually because we know in this country HIV AIDS was mainly found in gay white males in large metropolitan cities. And over the decades, 30 years later, the epidemic is largely African American, both male and female. And not only in large cities, but in small rural areas and in smaller communities. And particularly, it has shifted from the east and west coast of the United States to now the south, the deep south, where I am in Alabama. So the question was why? And as I began to look at the issue, look at the data, there was a question of whether or not there was more stigma around HIV, so that we couldn't really, our prevention efforts were not effective. not as much advocacy around HIV, particularly in smaller rural areas. And particularly as I began to do some research with a nurse colleague, we found that people living with HIV/AIDS said that where they felt most stigmatized was the church. And as we know, culturally in the South, it's a very religious area of the country, and that might actually be a barrier to really effectively dealing with HIV/AIDS in this part of the country. So I began to, and I did test an anti-stigma faith-based intervention, which was very effective. But I used some of the curriculum developed by a civil rights organization here in the United States called the NAACP, National Association for Colored People, so for the advancement of colored people. And so it's an old civil rights organization. You can tell by the name. They've maintained that historic name. But what they began to do was say, okay, we know HIV/AIDS is a public health issue, but in order for the church to embrace it, maybe we need to think about reframing it as a social justice issue. And that is very attractive to black churches because we know historically during the 50s and 60s, even before that time in this country, the black church was really paramount, was really a leader in dealing with the civil rights movement. Of course, we know Reverend Dr. Martin Luther King was steeped in the church as a pastor and was president of the Southern Conference, Leadership Conference. And so we know that the church really was involved in that way. So why not reframe this issue as a social justice issue? And really the way they did it, I'm looking at an infographic now, was to really talk about the numbers being so disparate compared to the white population that we could compare it to other social justice issues. So, for example, they looked at the black male U.S. population being 11%, and the HIV diagnosis in black males at 42%, very disparate. Same thing for women. We make up 12% of the females' U.S. population, but 64% of female HIV diagnosis. And really, the one statistic they used to really bring this home was they said, if Black America were its own country, it would rank 16th in the world in the number of people with HIV, which is very, very graphic. What they did was compared HIV to other social justice issues, like the rate of new AIDS diagnosis, 75.6 per 100,000 black males compared to 9.1 per 100,000 white males, and compared that to other statistics like those living without health care coverage, 17% of blacks compared to 11% of whites, 36% of blacks in poverty compared to 14% of whites, and high school male graduation rates, only 47% for black males and 78% for white males. But the statistic for HIV is so much worse than those social justice issues, but the only one that really ranks sort of commonality with is that of incarceration rates, which we know incarceration rates are extremely high in the United States compared to other westernized or comparable countries. But the incarceration rate for 18-year-olds and older is 1 in 15 in black men, which is extremely high. And they compared that to the HIV diagnosis rate over a lifetime for 1 in 16 for black men will be diagnosed with HIV in his lifetime. So that's startling. And they said that the church is really the right place for this, for action, for the church to be involved. There are 21,000 black churches in the U.S., quite a bit. And most African Americans in the U.S. say religion is very important in their lives. Based on a poll, 79% say that it's very important in their lives. And if we look at the fact that there are 39 million blacks living in the U.S., 53% of them say they attend church regularly, that's a lot of people who have the power to end HIV/AIDS, 20 million. So I'm going to end now with a quote that really brings home why we need to begin to look at we as healthcare providers being involved in social justice issues. And there are many. At the conference, I talked about some that I think we need to probably be more involved with. Here in the U.S. is the gun control, gun violence issue. We have a great opioid abuse problem right now in the United States, which is another issue, and the incarceration, as well as police brutality issues in the United States. I think many have heard of the Black Lives Matter movement. I think we have to be involved as well. But I'll end with this quote from the Reverend Dr. Martin Luther King Jr. He said, during that time, we are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. So I thank you very much for your attention, and I look forward to hearing from some of you. My email is pfoster@ua.edu. Thank you very much. Bye-bye.